We eat, the air we breathe, the soil below us and inside our bodies. And children in low-income countries face higher risk due to the improper waste disposal, proximity to the burning sites, and limited access to the water and safe food. And this gentleman is Mr. Leo Baekeland, who invented this Bakelite, which is a non-recyclable plastic in 1907. But before that, 1862 itself, Alexander Parks made the first man-made plastic, that is Parkinson. And among the countries, Rwanda is a North American country, has banned plastic bag since 2008. Morocco, South African country, single-use plastic ban since 2016. And Norway leading with the plastic bottle recycling initiatives. So where India stands regarding plastic pollution, globally the plastic production has doubled in the last 2 decades, and it is going to triple by 2060, and output also doubles shortly. And the USA recycles only less than 6% of its plastic waste. China, among the countries, 2/3 of the plastic production by 7 countries, of which half is by China itself, around 34%, and United States 13%, Saudi Arabia 5%, India 4%, Germany and Japan less than 3 and 2%. So while India's plastic production is in highest, its waste management system struggle, because the global plastic production, 20% of the plastic waste accounted by in our country, around 9.5 million metric tons, and of which around 8 to 60%, it's not 60%, it ranges from 8 to 60% of the plastics is processed, and almost 50% is ending in landfills and water bodies. About 5.8 million metric tons of waste is burned openly. So among the states producing plastic waste, Chandigarh leads with 3.1% and Surat with 12.4%. And this plastic, 40% of the plastic is used for packing. So let us see the different types of plastics. So this, you must have seen that, I don't know how many of you have noticed this bottle and the number of that bottle. Any bottle, you should look at the number. It is, fortunately, this bottle is number 2. And 1, 2, and 4, 5 can be used safely. And 3, 6, and 7 is not good to use. So one is the polyethylene tetraphtate used for soft drink bottles, furniture, etc. And high density polyethylene is number 2. This is the bottle we have. So any bottle, we should look at the logo of this recycle, whether it is recyclable or not. In this we have logo here. It's a recycled bottle, so we can use it. Previously it was not like that. And the PVC, the code number 4, that is low density polyethylene, is also used for plastic bags. And the polypropylene, that is code number 5, used for industrial fibers and food containers and all. So what we should not use is 3, 6, and 7. That is 3 is PVC in windows, pipes, and flooring, shower curtains, etc. And polystyrene, that is most dangerous, that is used in our toys, video cassettes and CDs and all. And the code number 7, that thermoset plastics, that is from later, and multi-layer packaging, backlight, all these are non-recyclable, which should not be used. And plastics in general is made of polymers and additives. Polymers accounts for most of the content of plastics, which is PVC, high density polyethylene, and polypropylene. Whereas additives is, even though it is less, the main additives are the phthalates and the bisphenol A. These phthalates and bisphenol are called the plasticides, and they account for the color, fire resistance, strength, and flexibility of the plastics. The strength of the plastics is by bisphenol A, and the flexibility is by the phthalates. And plastics can also be classified into 2, that is thermoplastics and thermosets. Thermoplastics are they can be molded into different shapes, so it can be recycled. Whereas thermosets cannot be recycled because like sheet molding compounds, fiber reinforced plastics, etc. Bakelite, because they have got irreversible chemical bonds which cannot be recycled. Next is about the single-use plastics. You know, India banned these single-use plastics in July 2022. And we have the single-use plastic like food containers. For the takeaways are single-use plastics. Then food wrappings, beverages of less than 3 liters, coffee cups, lightweight plastic carrier bags which you use from shops, wet wipes, balloons, and filters for tobacco products. All these are single-use plastic which are not supposed to be used. And there is a penalty for that if you use that 500,000, but it is like our IMS Act only. Nobody is fined even if you break this IMS Act. So these are the various plastic which are allowed. That is, you can see, these are plastics. It's not like that formula fish should not be used totally. Like that, plastics is not that plastic should not be used totally. Those recyclable plastics can be used, and this is all these are can be recycled. Or has to be, that label should be there, recyclable plastics. Whereas some of the plastics are not supposed to be used and should is banned. Like our when you go for shopping, no, we are not supposed to give. Since the last 2 years, nobody is giving plastics, but small shops they give still plastics. So the thermocols, we use thermocols that is not good for health. And the key reasons for banning plastics, single-use plastics as non-biodegradability, harm to marine life once it is disposed, and contribution to the clogged system, release of harmful chemicals, high cost for cleaning, reliance on fossil fuels. Plastics are made from, 99% of the plastics are made from fossil fuels, and availability of eco-friendly alternatives. So these are the reasons why single-use plastics are not used. And coming to the source of exposure, from where our children are affected. This from toys, baby bottles, household items, food packed in plastics, microplastics in the air and dust, and through inhalation we get it. In schools, the plastics are seen in furniture and playground equipments, and older children and adolescents, even though we don't use much e-cigarettes in foreign countries, other countries, e-cigarettes are used. So, phthalates, as I said earlier, phthalates is the most, phthalates and bisphenol A, they are the most culprits. So diethyl phthalate is seen in our day-to-day use like nail polish, perfumes, aftershaves, pharmaceutical products and cosmetics. Dibutyl phthalate also like that. Diethyl hexaphthalate used in PVC, that is my component of PVC, contains our medical equipment, medical tubings, blood storage bags, food packaging, all this contains this diethyl hexaphthalate. And butyl phthalate is in vinyl flooring and adhesives and food packing. The most important topic of today's my session is the effect on how it affects our children. Before that, just a word on the environment, how it affects the environment. In the marine environment, plastic pollution causes entanglement, toxicological effects via ingestion of plastics, suffocation, provision of new habitats, and introduction of invasive species. Around 250, more than 250 species are tangled in plastic after ingestion. And how it affects the climate change, because it releases a lot of carbon dioxide, and in 2019, 850 million tons of carbon dioxide is released, and it is going to double, almost double by 2030, and so that will account for almost 14% of the Earth's carbon budget. Plastic contributes to carbon footprint. And the third thing is about the tap water. As you can see, America, USA, 94% of the tap water is contaminated with the microplastics. In India, it is around 82%, and other countries 70%. So our tap water is all contaminated with microplastics, which can cause, what are the effects of microplastics will come later. Then soil contamination as well as flood. Flood is because the plastic clogs the drainage and impedes the sewage flow, causing clogging of the drains and flooding, and disruption of the aquatic ecosystem and soil and water contamination. So these are the various effects on our environment. Now let us see what is the effects on our children. So the phthalates and the bisphenol A, they are the more culprits. The phthalates are otherwise called, they are also environment, it's a plasticizer. This phthalates and bisphenol A are plasticizers. They causes a disruption of the hormones, causing obesity, hypothyroidism, all hormonal problems. decreased reproductive problems like decreased sperm count in women, in men, and undescended testes, hypospadias, if they are exposed during the 10 to 13 weeks of gestation, developmental delays, ADHD in children. So this, the routes of exposure is ingestion, inhalation, IV, and dermally absorbed. The dioctyl phthalate is extensively used plasticizer in PVC, but it is classified as a toxic chemical by US Environmental Protection Agency. And as I said earlier, the most sensitive period is during the 10 to 13 weeks of a pregnant lady. And increased phthalate exposure through human milk has associated with changes in the luteinizing hormone-free testosterone and sex hormones. And the dihexaethyl phthalate and butyl phthalate are immunologic dysfunction, risk of allergic rhinitis, eczema, and asthmatic symptoms. Next comes the BPA. The bisphenol A, in one study, it has shown that in America, almost 95% of the population has got bisphenol A in their body. The many hard plastics that use every day contains bisphenol A, like bottles, dental seals, CDs, electronics, and sports equipments. And it causes endocrine dysfunction, erectile dysfunction, infertility, and immune dysfunction, and also causes birth defects, preterm deliveries, etc. And it also causes, BPA causes the hypothyroidism because it affects binds to the thyroid receptors. Other effects by BPA is the ovarian dysfunction, diabetes mellitus, and heart disease. And one small study in pregnant women showed if they are exposed during the prenatal period, the children can have the behavioral problems. Other effects include eye irritation, vision problems, skin disease, headache, dizziness, cardiovascular disease, and genotoxicity. Then about polybrominated diphenyl ethers, there is another like phthalates and bisphenol A. These polybrominated diphenyl ethers is a content of flame retardants in building materials, and this, when plastic is burned in air, it releases dioxin and produces the reproductive and developmental problems, and immune system is affected, producing even cancer. The ingested plastic may also affect the nutrition, gut health, and liver dysfunction. And in breast milk, in 2022, a study came that breast milk of lactating mothers contain 77% of the lactating mothers contain these microplastics. And these microplastics lead to asthma and respiratory infection. And in 2022, a study published in Environmental International Journal found in 80% of the people tested, and can also affect the reproductive organs. In another study, the effect on carotid arteries, 58% of the patients who underwent vascular surgery had invisible plastic nanoparticles in their carotid arteries, and the blood vessels were also inflamed. And this polyethylene is another that is code number 7 in the plaque tissues underwent carotid endarterectomy. Now, solutions to this problem. This, as you all know, recycling. 3 R's you all know about plastic pollution. So the most important is recycling. How to recycle this plastics? It's very easy because 94% of the plastics are recyclable. Only 6% is non-recyclable. So the 94% includes the number 1, number 3, number 1, number 2, 4, and 5. 3, 6, and 7 are not recyclable, and the non-recyclable includes the thermocoals. We use a lot of thermocoals. Then multi-layer packing. Multi-layer packing means there will be at least one layer of plastic in that cover. So that is multi-layer packing. And the non-recyclable, multi-layered, and metallized plastic waste and thermoset plastic waste are also come under the classification of non-recyclable plastics. So that has to be properly disposed. So following options are envisaged for the utilization of recycling of plastic. The 4 important points. One is use of shredded plastic waste in construction of bituminous roads through hot mix plant. Second is conversion of plastic waste into liquid fuel. Third is about transporting into cement kilns for processing. And lastly, transfer to recycler for recycling into other products. Aluminum cans is the best thing to recycle. So plastic waste into fuel, how it is done, except PVC, all other plastics can be done at high temperature. These polymers are converted into small chain hydrocarbons, and the vapors are condensed in condensers and collected as plastic fuel oil in different grades. And this is done in not much places, only in Vadodara and New Delhi. And the co-processing of plastic waste in cement kilns, that is at 1400 to 1500 degrees centigrade, the long residence time in cement kilns, all types of waste can be effectively disposed without any harmful emission. That is the most important thing. Like e-waste also, if you don't properly dispose, it will cause harmful emissions and affect our health. So like that, plastic waste also should be properly disposed. And this technology is even in your place like Tamil Nadu, Gujarat, Karnataka and North Indian states. Now comes the recycling of the plastics. It comes under three categories. Category 1 is primary recycling into the similar product. Category 2 is secondary recycling into different product or material. And tertiary recycling is the, as I said earlier, to chemical or fuel. So the most preferred method for multi-layer packing, since separating the individual layers is costly. So this tertiary recycling is very important. Pyrolysis and gasification are the key technologies currently used for tertiary recycling of multi-layer packing. And for this, we have to obtain registration from the State Pollution Control Board. And recycling, just a word on recycling, how it is done. The 5 steps are there. One is sorting. Every plastic system item is separated according to its make and type. Washing is done to improve the, to remove the impurities. Shredding, identification and classification of the plastic, and extruding. That is, involves the shredding plastic into extruded pellets, which are then used for recycling. And lastly, the prevention and mitigation strategies. One is policy implementation, like banning the single-use plastics, which is done already. Strict regulation of plastic additives, and promoting extended producer responsibility for the manufacturers. Like e-waste also, manufacturers has got the responsibility. Then public awareness and education to use alternatives, health sector initiatives to incorporate plastic pollution in pediatric health programs, and community level interventions. And tips to avoid phthalates and bisphenol, as I said earlier.
Excuse me, sir. We are running short on time, so if you could just...
15 seconds more.
Yes, sir, please. Thank you.
So so do not microwave plastic in plastic, and do not microwave or heat plastic ring wraps, and avoid dishwasher plastics in dishwashers, and avoid phthalate-free toys, and ensure proper ventilation. So these are the various things. Stop buying water bottle, boycott microbeads, recycle, reuse, and ban all activities, and administration have to do a lot of things. And these you all know to straws, packaging, and everything. And conclusion is that plastic pollution poses an emerging yet under-recognized threat to child health. Reduce the plastic waste through voluntary agreements and plastic-free India initiatives like government campaigns, local government campaigns, startup innovations, and our grassroots workers. And happy news is that the Norway-style e-waste processing revolution is planned for Delhi. But the unfortunate thing is that the Intergovernmental Negotiating Committee on Plastic Pollution last week at Geneva, there is a deadlock between two blocks of countries. One block is for reducing the plastic production. The other is for not reducing the plastic production, but to manage the plastic waste by recycling. So that deadlock is still there. I hope that will be, we will have a good outcome shortly. So these are my references. Thank you.
Excellent and brief presentation by our beloved speaker. Any questions from the audience? Okay, there is no more questions. Thank you, sir. Please. And concluding remark.
One minute, sir. So request from I am the national chairperson of the Environment and Childhood Group, Childhood Chapter, and we are around 1,300 members. But in Tamil Nadu, you have your own leader, Dr. Narmada, as our leader. But we don't have much members from Tamil Nadu. I request everybody to take contact Dr. Narmada and take membership in the Environment Chapter. Thank you.
And concluding remark, we cannot change genes our children inherit, but we can change the environment they grow up in. That is our greatest responsibility. Thank you for our two eminent speakers for their wonderful insights, and all the delegates for your attentive participation. Thank you. Thank you, one and all.
Thank you, sir. We are grateful to our chairperson and both the speakers for a truly wonderful and enlightening session. I now request our chairperson, Dr. Sivanarayanan, to present a memento to our first speaker, Dr. J. Balasubramaniam, as a token of appreciation. Thank you, sir. I request our chairperson to present a memento to our second speaker, Dr. Balachandar. I finally invite Dr. Balasubramaniam to present a memento to our chairperson, Dr. Sivanarayanan, in recognition of his leadership in this session. Thank you, chairperson and speakers. So we have two more sessions before lunch. So to chair the next session, we have the esteemed Dr. M. Manikavasagam, Director of Lakshmi Madhavan Hospital, Tirunelveli, with 25 years of experience in pediatrics. He has held key roles and leadership roles in IAP, including being the treasurer and executive board member, and was the organizing chairperson of the highly successful KONGU PEDICON 2024. Currently, he is serving as the president of IAP Tirunelveli branch, and he is a respected clinician and an active contributor to pediatric healthcare and education. We welcome you, sir. I now invite the first speaker for this session, Dr. P. Selvakumar, on stage.
Thank you, Karthik, and the organizing team of KONGU PEDICON for giving me this opportunity to chair this session. And the speaker, the first topic is allergy asthma axis in children, simplifying OPD management, and the speaker is my family friend, Dr. Selva Kumar. And like delegates, I'm also eagerly waiting for your presentation. Over to you, Selva.
Very good afternoon to one and all assembled here. Firstly, I would like to thank the chairperson, Dr. Manikavasagam, for the kind words of introduction, and Dr. Jayavardhane, who has allotted me this topic. Like, initially, I was like hesitant to bite the bullet, like, because this is something like covering asthma in 20 minutes. The ATM module plus is a difficult task. I shall be confining to the basics, like what a pediatric generalist requires to know for practice in their OPD practice. Like, so where do you go? Not me. Slide is not easy. In the next 18 odd minutes, like I shall be presenting to you the burden of allergic disease in Indian school children. I shall be briefly explaining the allergy asthma axis and the atopic march. I shall be describing the diagnostic criteria for pediatric asthma. I shall be outlining the JINA asthma management strategies, and finally highlight the necessity for early recognition and referral of severe asthmatic patients. In the year 2021, like the Indian Journal of Pediatrics reported that 30% of Indian school children exhibit some form of allergic disease. The higher rates are contributed due to the rapid urbanization, pollution, and allergen exposure. What are the challenges, common challenges which we encounter? They are the underdiagnosed and mismanagement of these allergic diseases. There is a gross regional variation across India. According to the Global Asthma Network survey, which was conducted between 2017 and 18, the prevalence of asthma in children between the age group of 6 to 7 was self-reported Bs was reported as 3.2%, allergic rhinitis as 7.7%, and eczema was 2.5%. Atopic march refers to the progression of childhood allergic diseases, which starts in infancy as atopic dermatitis and subsequently progresses to food allergy, and in childhood to allergic rhinitis and asthma. Only 3% of the symptomatic children progress in the classical manner in the given trajectory. It there is a reflection from the skin barrier inflammation to that of the airway hypersensitivity. Will we be able to stop this allergic march? It is $1 million question. At this point of time, it is a strict no. Probably we may be able to mitigate the progression of these atopic disease. Early eczema results in an increased risk of asthma by twofold by school age. Early onset along with persistent eczema is strongly linked to persistent wheeze. If there is early eczema, like milder forms, nearly 20% becomes asthmatic later on. If the eczema is severe, then probably 60% become asthmatics. Children with IgE-mediated food allergy, there is a 2 to 3-fold higher asthma risk. If there is peanut allergy, nearly 60% develop asthma later in life. 20 to 40% of children with allergic rhinitis develop asthma. The risk is increased with multiple aeroallergen sensitization. In the past, there are two classifications of these. One is the symptom-based classification, where the children are grouped into episodic wheezers, where they wheeze with respiratory tract infection. They are, in the intervening period, they are asymptomatic. The other is the multi-trigger wheeze, where these children wheeze during the respiratory illness, as well as they are symptomatic in the intervening period, and they also wheeze during activity or during sleep. The next classification which has been proposed was the time trend based classification. This is based on a retrospective subsex which has been found in a large Tucson cohort, where they found the children who start wheezing early in life and the wheeze subsides by the age of 3 years are known as the transient early wheezers. Here, these children have a history of prematurity and they are being exposed to maternal smoking. The other subset is the non-atopic wheezers, where they have bronchial hyperreactivity. The wheezing starts before 3 years and continues beyond 6 years. The other group is the classical IgA associated wheeze or asthma, where they have personal history of atopy as well as family history of atopy. These classifications do not help us in prospectively putting a child into a particular phenotype of asthma. It will be really challenging when we use these classifications. So, the modified asthma predictive index is an assessment tool to predict asthma in children who are less than 3 years and who wheeze more than 3 episodes per year. The major criteria is parent with asthma, physician diagnosed atopic dermatitis, sensitization to one or more aeroallergen. The minor criteria is wheezing unrelated to cold, blood eosinophils are more than 4%, sensitization to food allergy. the index is positive and the child meets at least one major criteria or two minor criteria. The specificity of this in predicting future asthma is nearly 98%, but the sensitivity is very poor. It is hardly 20%. So there is high chance we will miss in predicting future asthma in children. The GINA in its 2024 has proposed a probability-based asthma approach. Here, it is based on the symptoms during the respiratory illness as well as in the intervening period. If the child is symptomatic, that is cough, wheezing and breathlessness lasts for less than 10 days with URTI, 2 to 3 episodes per year with no symptoms between episodes, very few have asthma. On the contrary, symptoms last for more than 10 days and there are more than 3 episodes per year with or severe episodes or night worsening, but in the intervening period there are few occasional cough, wheeze or breathlessness, some have asthma. If it's going to last for more than 10 days and more than 3 episodes, and the child with episodes of cough, wheezing and breathlessness during play as well as laughing, as well as the child has a personal history of atopy or family history of atopy, then most of these children have asthma. So the qualifying features, to put it in a nutshell, is episodic airflow obstruction more than 3 per year, afebrile episodes, nocturnal or seasonal exacerbation, trigger or exercise-induced symptoms are there. If there is relief with bronchodilators along with a short course of corticosteroids is there, personal atopy, that is like prior to the asthma, there is eczema or food allergy is there, predates asthma. When there is a family history of atopy or asthma, then probably you are right in making a diagnosis of asthma. When asthma is not is the cause, if there is persistent wet cough, then you should think of other causes like protracted bacterial bronchitis or cystic fibrosis. If there is recurrent pneumonia, localized chest signs, probably it can be a foreign body or it can be a bronchiectasis. Failure to thrive or weight loss with digital clubbing can suggest cystic fibrosis or primary ciliary dyskinesia. Symptoms present since birth can give a clue if you ask for a history of prematurity. It can be a chronic lung disease or a bronchopulmonary dysplasia or any congenital cause. If there is a stridor, then you should think in terms of a vascular ring. If there is recurrent vomiting, then you will have to think in terms of GARD. If symptoms disappear during sleep, then you should consider psychogenic causes. So the diagnosis of asthma is basically clinical in children who are less than 5 years and mostly clinically in office practice. If you have access to spirometry, then it can give a objective diagnostic feature if there is increased FEV1 to more than 12%, 12 or more percent, or the GINA has also said we can use the peak expiratory flow. But only thing is you will have to measure it over a period of 2 weeks. Pheno and sputum eosinophils may give you a clue that the airway inflammation is eosinophilic, but they are in research settings. CBC eosinophilia and total serum IgE may give you a clue that the underlying cause is atopic. Allergy testing may help in identifying the triggers, and chest X-ray may help in identification of alternative diagnosis. What are the appropriate devices in children? In a child who is less than 3 years, pressurized meter dose inhaler with spacer with face mask is the ideal device, or nebulizer with face mask. In children who are between 4 to 5 years, MDI plus spacer with mouthpiece or nebulizer with mouthpiece or face mask is the ideal device. More than 5 years, it can be MDI with spacer or breath actuated inhaler or dry powder inhaler or nebulizer. You find here the most ideal device will be a meter dose inhaler with spacer, because the drug deposited here in the lower airway is around 10 to 20%. So when compared with the meter dose inhaler or the dry powder inhaler or the nebulizer, so the efficacy of the corticosteroids or your SABAs will be highest when you are using the metered dose inhaler with spacer. The oropharyngeal deposition with MDI with spacer is less than 10%, so the systemic side effects are less. The drugs which we usually use in asthma are the beta-2 agonists, the anticholinergics, the controllers, namely the ICS, budesonide, fluticasone, beclomethasone, and the LTRAs, the montelukast. What is new, what has been incorporated in all these guidelines in the last decade is the usage of anti-inflammatory relievers. That is budesonide plus formoterol or budesonide and a SABA for when there is active wheezing for reliever purpose. And similarly, budesonide plus formoterol has also been used as a reliever as well as a controller. What is MART? This is something new which has been incorporated in the GINA guidelines in the past few years. It is the usage of a budesonide that is an anti-inflammatory along with a formoterol, which is a LABA with a rapid action as a reliever as well as for maintenance therapy. It is considered as very low dose if budesonide is 100 microgram and formoterol is 6 micrograms. Low dose is budesonide 200 microgram with formoterol 6 microgram. The maximum daily dose of formoterol recommended above 12 years will be 12 puffs, whereas less than 12 years it will be 8 puffs. The advantages of MART is there is greater reduction of severe exacerbation, thereby there is lesser ED visits, there will be lesser cumulative steroid doses, there will be lesser oral contraceptive usages and better symptom control. The clinical equivalent ICS dosages for children 5 to 11 years are budesonide and beclomethasone. When we say low dose, it is 100 to 200 microgram. Between 200 to 400 is considered as medium, and more than 400 is considered high dose. Fluticasone is half of the dosage of budesonide and beclomethasone. Cyclophosphamide is not used in our country, but it is preferred in Australia, where the low dose is 80 to 160 is medium dose, and more than 160 is higher dose. These are the steps for initiating long-term ICS, as well as stepping up or stepping down. If the symptoms are less than 2 days a week, then what is recommended at present is low-dose ICS taken whenever SABA is taken. That is, whenever you give salbutamol, along with salbutamol, you use low-dose ICS. The dosage I have already depicted in the previous slide. If the symptoms are between 2 to 5 days a week, then probably you'll have to start on regular daily low-dose ICH. The next preference will be daily LTRAs or low-dose ICS taken whenever SABA is taken. If symptoms are most days or waking at night, once or more a week, then you will have to use either low-dose ICS LABA, long-acting beta-2 agonist, that is fluticasone with salmeterol, or a medium-dose ICS. Medium-dose ICS is between 200 to 400 for a 6 to 11-year-old child, or a very low dose of ICS formoterol, that is the MART therapy. Similarly, for step 4, that is you need an expert advice here, or where you can use a medium dose ICS LABA or a low dose ICS formoterol. Low doses, 200 microgram of budesonide with formoterol. Thing is here you can add LTRAs or tiotropium. And the fifth step is where you will need to use biologicals. For children who are less than 5 years, infrequent viral wheezing and no or few interval symptoms, there is insufficient evidence for daily controller. Consider here intermittent short course ICS at onset of viral illness. When there is a viral illness, you will have to utilize ICS maybe a budesonide 10 to 20 puffs per day for 10 days. This has been in the studies. There are no clear-cut evidence here. And in step 2, you use daily low-dose inhaled corticosteroids. In step 3, you will have to double the low-dose ICS. And in step 4, you can add LTRAs or use intermittent ICS along with the double dose ICS. You can find out whether the asthma is controlled by these 4 questions. That is, are the daytime symptoms more than twice a week? nighttime symptoms are there, limitation of activity is there a need for reliever more than twice a week? If the answer to all these 4 questions are none, then probably it is well-controlled asthma. If the answer is yes for 1 or 2 of these questions, it's partially controlled. And if the answer is 3 or 4, then it is uncontrolled asthma. If the child is having an uncontrolled asthma, you check the diagnosis, rule out alternative diagnosis, and you should see whether the comorbid conditions like allergic rhinitis, atopic dermatitis, GERD, obesity, sleep disorders, anxiety and depression, or have been treated appropriately. Then you will have to see whether the optimum dosage has been given, then appropriate device has been given, and whether the technique of inhalation corticosteroids is appropriate. You will have to also look into the triggers. It can be even as something like your mosquito coil burning in the house, or cockroaches or pets, or it can be some pollution, outdoor pollution. And regarding the adherence of the therapy. Tell me and I forget, teach me and I remember, involve me and I learn. So effective health education only can see to that these children, because it has been found out in studies, nearly 80% of the children are not using their devices or the drug appropriately in Indian setup. Teach back is a technique where you assess the understanding of the health information which you provide. Here you explain the information in a simple language, check for the understanding without shaming them, re-explain if there are gaps if needed, and recheck their understanding. If done properly, probably we'll become one of the best asthma specialists in town. You should ask them to maintain asthma symptom diary. Okay, incorporating several things like cough, breathlessness, wheeze, sleep disturbances, school absenteeism, and nasal symptoms, because this gives an authentic data for you to step up or step down therapy. And finally, you should also give them an asthma action plan where in the green zone, like what controller medications they are going to take regularly. If the asthma gets worse, what quick relief medications they will administer, and if it is severe, like what they should do and whom to approach for the therapy. While stepping down, if the symptoms are controlled for more than 3 months, you reduce ICS by 25 to 50%. If the child is using only ICS, then reduce ICS till the lowest dose is reached, switch to ICS to once daily, and finally use the step 1, that is ICS and SABA SOS. If you are using ICS with LABA, that is non-MAT, you similarly reduce it by 20 to 50%, reach the lowest dose, stop LABA and switch to ICS once daily. While using ICS and formoterol MAT, then probably you reduce ICS till the lowest dose is reached and switch to ICS formoterol SOS. Well-controlled asthma, when to stop treatment, you will have to assess how was the severity or seasonality of the exacerbation in the last 1 year, because that will help you in deciding on when to stop. Step down to appropriate step 1 therapy. Wherever feasible PFT has to be done, you avoid triggers and give them a home management plan for flare-ups. Follow up at 3 to 6 months for 1 to 2 years. Counsel them regarding the possible future resumption of controller if recurrence occurs. In our clinic, if a child comes to with mild to moderate exacerbation, inhaled SABA are non-inferior to nebulized Asthalin. So all that you need to give is for 5 to 10 kgs, 4 puffs by MDA plus pacer, 10 to 20 kgs, 6 puffs, more than 20 kgs, 8 puffs. And along with it, you should prescribe prednisolone. The only advantage of using nebulization is you can give ipratropium and oxygen along with it. When you're administering SABA, like for a child who is with a saturation less than 92%, what happens? The blood, because of hypoxic vasoconstriction, the blood goes to the well-ventilated pulmonary units, and there will be less blood going to the bronchoconstricted pulmonary units. So after administration of SABA, what happens? The vasodilatation occurs earlier when compared with the bronchodilation. So when the blood flows to the bronchoconstricted unit, there occurs a ventilation perfusion mismatch, and so the child can become really sick. So any child with saturation less than 92%, you please do like administer with oxygen and maintain the target saturation between 94 to 98%. There are umpteen number of pulmonary scores. One is depicted here. This will help you in deciding when you should send the patient to IMCU. These are the red flag signs. If the child is agitated, if there is altered sensorium, child is exhausted, absent breath sounds, feeble chest
Excuse me,
movements.
sir. We're just running short of time.
I started 2 minutes late.
Okay.
Okay. Cyanosis or oxygen saturation is less than 92%, then you will have to refer. So, like most of the, we do encounter patients who are brought to the medical college in a very moribund state with hypotensive shock or respiratory failure, because the practitioners, like when they see a child with severe or life-threatening asthma, they do not do anything. So please administer oxygen, administer inhaled SABA, inject them steroids, and transport them by 108 ambulance. So you treat and refer. The therapy is not recommended in acute asthma: sedatives, mucolytics, cough suppressant, chest physiotherapy, steam inhalation. Antibiotics have limited role, can be used for child with pneumonia, or there is radiological evidence of pneumonia. So the carry-home message will be early identification is the key. Diagnosis is clinical, looking for qualifying features, exclude alternative diagnosis, and use appropriate investigation for the diagnosis. Device choice matters to ensure effective drug delivery. Follow evidence-based protocols like the GINA guidelines. Use smart therapy appropriately, and you should know when to step down or step up the treatment. Recognize and act on the red flags, which can be life-saving. Thank you. Sorry for exceeding the time.
Thanks, Dr. Selvakumar, for the excellent talk. I think within 20 minutes you have simplified the asthma management. Any questions? Yeah.
Space volume can be anywhere between 300 to around 300 ml will be the ideal. It can be things like it all depends. If it's a valved spacer, if you just tilt it, it will automatically go. Of late, the non-valved spacers are not available in the market. So you can use the valved spacer for even toddlers.
Okay, thank you, Selvakumar. And we'll move on to the next topic. The topic is atopic dermatitis in 2025. What's new and what works? The speaker is Dr. Jose Joseph, and he is a professor in Coimbatore Medical College, Alappuzha, and State President NN of Kerala 25-26, and he is the National Secretary by State Secretary NN of 2013 and 2014. Over to you, sir.
Thank you. Good afternoon to all. At the outset, thank the organizing team given the opportunity to talk on one of the common topic in pediatric practice, atopic dermatitis, what is new and what works. Already Dr. Selvakumar sir covered the topic of allergy asthma in extensive and a large topic covered with 20 minutes. Congratulations sir for covering all the topic in an excellent manner. So, as you know, allergy disease basically it's a day-to-day practice. Commonly various allergy diseases come across. One of the common scenario come across is, apart from allergic rhinitis and asthma, another common entity we come out of pediatric practice is atopic dermatitis. It is one of the most common chronic relapsing skin disease seen in infancy and childhood. So what is atopic dermatitis? It is a chronic inflammatory condition of the skin characterized by dry skin, relapsing symptoms of scale lesions, and there will be, like any other allergy disease, there will be positive family history and there will be high level of IgE. So basically, atopic dermatitis basically three pillars for pathogenesis. Basically, the genetic in the background with immunological dysfunction and skin barrier dysfunction and triggering factor. Usually, the clinical presentation of atopic dermatitis occurs in children. So basically, the genetic disorder, basically all allergy disorder, there is a genetic background. The atopic dermatitis is also genetic background. It's a polygenic entity. The mutation of the skin barrier gene like a filaggrin, leucine and ilvorcine are the major genetic defect noticed in allergy disorders in atopic dermatitis. The atopic dermatitis can be associated with other general, some systemic conditions like ichthyosis vulgaris and viscotal syndrome or other hyper-IgE syndromes. So basically the pathogenesis of allergy disorder, basically the interaction between Th1 Th2 imbalance. Basically Th2 activation occurs and they lead to down regulation of the antimacular peptides leading to defect in the deficin and caxidin. That is the main reason of a recurrent infection in a skin with atopic dermatitis. So basically the genetic background with the immunological pathology, and there will be the mutation skin barrier gene, and the filaggrin gene mutation is a basic defect. That due to the filaggrin mutation, there will be defect in the skin epithelium that lead to the entry of the allergens into skin and lead to all immunological response in a child with atopic dermatitis. And in the background of this genetic background, there is a environment factor, and like any allergy disorder, there will be environment factor will be the triggering factor for atopic dermatitis. Basically the climate change, that is a major deposition factor. There will be change in the climate change, there will be the dehydration of skin going to occur. And again, the studies have proven that urban children versus rural setting, there will be increased incidence. And again, the triggering factor like air pollution and food allergies also documented a child with atopic dermatitis syndrome exacerbation. And again, they prove that already they are early exposed to non-pathogenic microorganisms can lead to early atopic dermatitis. Again, one of the studies have proven that water hardness, there will be increased level of calcium carbonate in the water content. That may be the earlier clinical presentation of a child with atopic dermatitis. Basically, with this pathogenesis, basically the clinical features, hallmark symptoms of atopic dermatitis will be itching and dryness of skin in the hallmark. Along with there will be scaling, erythema, oozing and casting and lichenification, depend upon the acute to the chronic stage of atopic dermatitis. So the clinical presentation in a different age group, there will be pattern of affectional involvement of the body part is different. That is why it classified into infantile form and childhood form and adolescent forms. Basically, the infantile form usually the common occurrence between the age group of 3 to 6 months of age, and usually start the erythema lesions will like a scaling on the skin is usually a character feature will be there, and there will be followed by there will be involvement of cheek, scalp and neck, and there will be one of the important differential feature to differentiate between the atopic dermatitis with other lesions. The usually the external surface there will be sparing of the diaper area in the younger the infancy is the character feature. If the involvement of diaper area is here, you have to rethink before making the diagnosis of atopic dermatitis in the younger the child is concerned, because that is a situation there will be sparing of the area with diaper areas. The childhood area, there will be usually the followed by the oozy lesion, there will be usually involvement of initial period, there will be extensor surface, then followed by flexor surface of like antecubital fossa and popliteal area, the common involved, and other area part of it can be also involve the child. As age advances adolescent period, there will be again there will be chronicity going to occur in atopic dermatitis. There will be lichenification of the affected flexure site will be there, and there will be site specific in the younger age like eyelid dermatitis, hand dermatitis, dehydrated eczema, nummular eczema or nipple eczema, and acral eczema is a common finding in a child with atopic dermatitis. So like any other allergy disorder like the asthma or allergy rhinitis, the food allergy, basically the diagnosis of atopic dermatitis is always clinicals. And again, there are different criteria to make a diagnosis clinically. There are half-in-jack criteria. Barely there are 4 major and 23 minor, but there is a difficult to remember all things. So there is a simplified and different criteria is there. Major criteria of atopic dermatitis must be, there must be the pruritus is the hallmark, the mandatory, followed by there will be a typical presentation of morphological distribution of the child, like a skin lesion involved in the fracture aspect in the younger the child, and fracture and like infection in the older adults, and there will be chronic and relapse in nature. So it will be any child having a chronic and relapse in nature will be there, and then there will be the background of positive family or personal history will be there. Asthma or hay fever, you have to make a diagnosis. So out of the 4 criteria, 3 criteria, one is pruritus is mandatory. Out of this 3 out of 4 criteria, even clinically you can make a diagnosis of atopic dermatitis. So once you diagnose clinically by the criteria, then you have to do with the severity. The atopic dermatitis is very important to management part is concerned. So there are again the atopic dermatitis, there are different scoring systems. The most important one is SCORAD index. Basically, the scorecard index depends upon the extent of involvement of skin involvement along with the intensity of the symptoms and again the subjective symptom of the patient. Based on that, there are different scoring systems will be there. I think this is freely available on our website. You can download it and keep your examination table. We can easily make a diagnosis, and the score is less than 25 will be the mild, and if the moderate will be 25 to 50, and if the scorer index more than 50, you can label diagnosis child having a severe atopic dermatitis concern. So this is you can get it and can download from the site, and you can do the clinical practice day to practice. So diagnosis, any diagnostic tool we can use. Basically, the basic clinical diagnosis, basically any allergy disorders, when come to the patient, they want to do a lot of investigation the child is concerned. Regarding to the atopic dermatitis concern, total IgE estimation is not at all useful for diagnosing atopic dermatitis, because if you do the total IgE, that indicates child having atopy. This atopy may be different etiology may be there, so it then does not give the clue to the diagnosis of atopic dermatitis. And again, there we have to the specific, it's having a specific substance triggering factor, exacerbation syndrome. We can do the specific IgE estimation. That we especially the important for a child having a food allergen triggering for atopic dermatitis. We can do the specific IgE estimation, and you can do the negative predictive value. If there is positive for that important for a food allergy is concerned. Again, already morning you have discussed regarding other investigation. Eosinophilia is also not at all much important regarding make a diagnosis. So usually not recommended, no specific biomarker is recommended for diagnostic assessment of severity of atopic dermatitis, basically clinical diagnosis and severity scoring. And monitoring IgE level is also not important. Routine allergy testing or atopy patches also usually not recommended in a child with make a diagnosis of atopic dermatitis. So once you make a clinical diagnosis, the treatment plan of the atopic dermatitis, basically the pathology in the acute dermatitis is a chronic inflammatory condition. Basically, first step we have to stop inflammation, and the second step is to prevent the recurrence of symptoms, and again we are using a multiple modality of management. Treat the patient safely and sustainably is the modality. These are the three cornerstones the management. You make a diagnosis and initiate the management atopic dermatitis concern. So initial step, first and foremost must be a clinical diagnosis. Basically, the patient parent education is very important, and bathing part of the child is very important, and moisturizers I come to detail one by one. Basically, any atopic allergy disorder, basically the environmental avoiding the triggering factor is very important. You have to the environment factor, food allergen, clothing and setting, and all the factors to be considered basically before going to start with the child with atopic dermatitis. So parent education is very, very important. So older children we can say counsel the patient and parent, and again younger the child, both the parents are properly counseled, because it is a chronic inflammatory condition, and there will be what are the therapeutic options also should be informed to the patient, because some stage of atopic dermatitis we want to use a steroid, that also should be properly counseled. And again explain it's not a acute condition, it's a chronicity of the atopic dermatitis is very common. I explain the treatment details and how to again atopic dermatitis, one important comorbidity usually associated with the secondary bacterial infection, because already know the leakage of epithelial bacterial infection, there will be immunological dysfunction, there will be more chance of bacterial infection will be there, that should be considered. And again basically the counseling important for regarding avoiding the trigger is very important for a child with a parent. So parent education is very important. Again you have to be considered, because the bathing is very important, and that very important for child with atopic dermatitis, because we have to remove the crust and scale and allergens in the body surface. Ideally the recommendation is lukewarm water. Ideally the prolonged bath is also not recommended. Ideally maximum time permissible is 5 to 10 minutes. And again avoid lengthy bathing should be avoided. And again whenever bathing issues comes with atopic dermatitis, just question will be what are the soap recommendation will be there. Ideally the neutral pH, so because majority of our soap is alkaline soaps, basically our skin is basically towards acidic pH. So basically neutral pH between 4.5 5.7 is ideal soap is recommended for child with. Again the soap have already dry, because already in the pathology of atopic dermatitis there will be dry skin will be there. Again if you alkaline soap there will be more dryness will be there. Then there will be more itching and more scratching will be there. So the clean thoroughly but gently, but again counsel the parent, because already there is epithelial barrier dysfunction. Avoid strong scrubbing and rubbing is very important, because again there will be epithelial barrier dysfunction going to happen. So you have to again and again avoid all perfumes, so because that may be again triggering factor of exacerbation symptoms. Ideal is synthetic bath is bar soap is usually recommended. Neutral to low pH, hypoallergenic, non-irritant and fragrance free are the soap recommended for the child. Again, synthetic liquid cleansers are more efficient than a synthetic bar soap bars. Liquid cleaners are usually do not alter the normal skin maturation process, that by more recommended for child. Clothing, again, clothing is very important. Better to use cotton clothing is very important. Synthetic, again, there will be more dryness and more itching will be there. And again, avoid tight clothing is very important for child with any child having any skin lesion, immediately the parents have concern that having food allergy. So basically, food allergen can be trigger the exacerbation of dermatitis, but you have to be very cautious, and typical history is very important to consider before going to restriction of food items. So basically, there is no empirical restrictions not recommended to the patient, and food should be restricted if they having definite evidence to clear-cut evidence of clinical evidence of exacerbation syndrome, and again that should be also counsel the parents. The moisturize is a very important. Regular use of moisturizer is a main step the management of child. Once you avoid the triggering agent, next step will be the moisturizer management. It should be can use all the severity of soap, mild, moderate, severe advantage can use, and replace the water. The advantage of moisturizer will replace the water loss from the skin and lubricate the skin and reduce scaling and scale the statin corneum are the modality advantage of using moisturizer. So moisture should be used at least twice in a day, and basically you have to advise the parents, you have to liberal use of moisture is very important. Again, when you use the moisture, ideally you have to be after bath within 3 minutes you have to do the moisture applied. Again, if the moisture should be continuous use, we have preparation like a tube or in the jar moisture available. Always use spatula to use rather than a hand and to take the moisture from the jar, because there can increase chance of contamination will be there. And again, once you apply the moisture, always use the downward direction to ensure the direction of hair fall, because do not irritate the hair follicles. So again, once you start with the moisturizer in other management, reactive and proactive management. Reactive management is acute management of child with a short-term management, and long-term management is proactive management, preventing the excessive dermatitis. So corticosteroid is the cornerstone anti-inflammatory medication. There are different potencies available. There will be the choosing corticosteroid depend upon the potency, because of mild potent steroids are usually recommended in younger child. They depend upon the symptoms, delivery vehicle, site of application, duration treatment is very important. So usually the younger the child is recommended, while group 4 or group 6 corticosteroids are recommended, like hydrocortisone, desanoid or fluticasone, acendoid are usual recommendation. And in younger, the older children, we can use mometasone furoate and beclomethasone valerate and fluticasone furoate are usually recommended. So how much here usually is also very important. We have to do the fingertip unit. If you take if you take the corticosteroid and the tip of the finger, that is equivalent to that both hand length area you can apply for the child in the word surface. So that is not a fingertip unit. So how long you can use in acute exacerbation at 2 weeks are usual, and review the child, and corticosteroid and betazoid may be used can use it up to maximum 4 weeks. And again, other modality of management is the topical calcium inhibitors with tacrolimus and beclomethasone are usually recommended, and can do the moderate severe. You can do the when having a child having a need for longer corticosteroid medication, we can ask for a topical calcium inhibitors. So regarding the topical calcium, they are safe in children. Most common side effect is skin, only thing skin barrier. There is not increased bacterial infection, or there is no chance of malignancy in the future. So other group of modalities are new modalities are phosphatase inhibitors. That is crisaborole is one of the new modality available, phosphatase for inhibitor, that can use above 3 months of age. And again, other modality, other phosphatase is the roflumilast, the potent phosphatase inhibitor. Again, 2024 that is recommended, FDA recommended for use in the younger children more than 6 years of age. So the JAK inhibitor as a new modality, the roxalintimab is used approved by FDA by 2021, and you can use the immunocompetent children about 2 years of age. It is not freely available in India. And other other modalities are therapeutic diflaminilist and bebropizumab are the new modalities of medicine available in the child. So again, in a child having a atopic dermatitis exacerbation, always there will be itching will be there, and always there will be, it will be, because once he itching and scratching the child, there will be more chance of skin epithelial dysfunction will be there. So to control the, basically the recommendation is child is first generation antihistamine, or those children have school going children, we can use second generation, otherwise first generation antihistamine recommended only in this situation with atopic dermatitis. So suppose child having a severe acute and atopic dermatitis, you have to severe degree and severe extent of involved atopic dermatitis, or there be atopic dermatitis are having impaired the quality of before with the use of corticosteroid and most child having severe symptom, we can use systemic steroid, and the modalities are the systemic corticosteroid, cyclosporin, methotrexate, phototherapy, biologic like dupilumab, azathioprine or macrofluvital are the drugs available. Or which most commonly we recommend is usually use corticosteroid is, but problem is that there will be dramatic improvement in the steroid and oral medication, but it will be rebound flare will be there. So this is usually the very short duration we can use for acute flare up of illness, we can use by usually 4.5 milligram per kg per day. And again, as far as possible, better to avoid using a systemic corticosteroid in atopic dermatitis. So other modality you can use is having a systemic cyclosporin. It is a potent immunosuppressant drugs acted primarily by T cells, and it can be 5 milligram per kg. You can use a prolonged period. There is no chance, but as we always, child should be closely monitored. Child having nephrotoxicity, hypertension, and hypertoxicity are common side effects you will keep in mind. So phototherapy, UV therapy can be one of the most useful treatment modalities. Moderate severe atopic dermatitis. And UVA1 acute phase we can use, UVB in the chronic phase we can use the phototherapy, and that is the field of dermatology part is concerned. This is another systemic drug we can do, the dupilumab. It is a IL-4 inhibitor, and because it will inhibit IL-4, IL-30 will be there, action will be there, and that is some factor for severe itching can use for that also, that are available. But problem is that once you treat the patient, once stop the drug, there will be rebound of symptom will be there. In the summary, basically, you have to start the child with a basic treatment, zinc hydration, emollient, avoidance of irritants, identification of addressing specific triggering factors is the basic modality. And if you are having a step 2 management, the low mild potency corticosteroid or topical calcium inhibitor we can use. And if child is still not responding, high potency corticosteroid and short duration and topical calcium inhibitor. And if still child is not responding, mild and severe exacerbation can do by the systemic medication already mentioned. Take a message, the atopic dermatitis is the most common and chronic relapsing condition of the child. It is the entry, already we are discussing, it's the entry point of atopic barch and followed by food allergy and allergic rhinitis and asthma. Moisturizing is a major treatment of the atopic dermatitis. Topical corticosteroids are the most important anti-inflammatory agent in atopic dermatitis, and those children having need a prolonged of corticosteroid, we can use the topical calcium inhibitors, but very safe in children, we can use along with the moisturizing agent. And again, before going to start, patient-parent education is very important, because adherence of patient is very important, and severe atopic dermatitis is very, very rare in pediatrics, and treatment up to topical calcium inhibitor we can done by the clinical practice by the pediatricians. And whenever the child having not responding, again you have to be analyze the history, avoid the triggerant, and proper adherent medication is very important factor. If child still not responding, you have to consider differential diagnosis for the condition. You have to re-evaluate the child for the possibility. Majority of the cases can be easily managed. I think this is a situation we can definitely manage by atopic dermatitis by pediatrician, and that is very important. Thank you for personal learning. Thank you.
Thank you, Dr. Jose. I think in 20 minutes you have covered almost everything about atopic dermatitis. Thank you, sir. Since we have one more session before lunch, we will conclude the session. No more question and answer session. Thank you.
Thank you, sir. I now request our chairperson to hand over the mementos to the speakers. Dr. Manikavasagam will now hand over the memento to Dr. Selvakumar, and to our second speaker, Dr. Jose Joseph. memento. I request Dr. Selvakumar to hand over the memento to our chairperson, Dr. Manika Vasagam. Thank you, sir. That was a wonderful session. Now we go on to the final session before lunch. And to chair this session, I call upon Dr. Ambrose Raju. Sir is the EB member of IAP-TNSC. He is also the treasurer of IAP Dindigul District Branch. Sir is a former medical superintendent at St. Joseph Hospital, Dindigul, and he's presently practicing at Baby Care Hospital, Dindigul. So, the first speaker of the session, I invite Dr. Nehal Patel on stage.
Good afternoon, everyone. Today we have two topics. The first topic is bleeding in hemophilia, and the speaker is Dr. Nehal Patel. Nehal Patel is the professor and head of the Department of Pediatrics at GMERS Medical College, Ahmedabad, Gujarat. And she is a EB member in state and central levels, and she is the leader in teaching in many aspects. Over to Dr. Neha for how to manage bleeding in a hemophilia. Okay.
Thank you so much. Do we have a slide changer? Laptop only? Okay. So, before lunch, with the low glycemic potential, I am starting with the acute bleeding in hemophilia. So how many of you really manage a hemophilia case? No? Okay, so I think this will give an insight to start managing some hemophilia cases. So let's start. What is hemophilia? As you all know, it's a inherited bleeding disorder that is associated with the deficiency of either coagulation factor 8 or 9. And most of these cases, we have the incidence of about 1 in 55,000 for the hemophilia 8 and 1 in 30,000 for hemophilia B. So genetics, as we all know, factor 8 and factor 9, they are linked to X chromosomes, and that's why it is an X-linked recessive disorder. We all know when there is mother is a carrier and the father is normal, only the male child will be having hemophilia. And the female will again have a carrier, otherwise two can have 50% chances of normal child, and where the genetic diagnosis plays a role. If the father is hemophilic and there is mother who is normal, the male child are not going to be having disease, but yes, those female child will be carrier, though they will not be having disease. And a rare combination of having carrier mother and the affected father, then even a female child can be hemophilic. So it's not like that a girl will not be hemophilic. What is the status of hemophilia in our country? So because of the diagnostic availability, nowadays we are expecting more and more diagnosis of hemophilia A and B, and that's why the rates is increasing, the number is increasing, and now in 2022, we are having hemophilia A in the world around 2 lakhs, and in the India it is about more than 21,000, while hemophilia B is around 3,500. It is still increasing day by day. So clinical phenotypes, if we check the phenotypes, what presents with the bleeding is generally the severe cases, which are having less than 1% of the normal concentration of the clotting factor. So factor 8 or 9. And these children are especially a problem because they are having spontaneous bleeding. And if there is a lesser severe variety that is known as moderate hemophilia, where the factor concentration will be around 1 to 3%, 5% of the normal, they may have the occasional spontaneous bleeding, but generally they don't much present with the spontaneous bleeding, but their bleeding will be with the minor trauma. And the mild variety, they are having factor concentration more than 5%, and they generally don't present with any type of spontaneous bleeding. But yes, the bleeding will continue if they have a trauma or the surgery. So these are the general bleeding sites and symptoms where the patients present with the bleeding. Majority of the time, the spontaneous bleeding, they occur in the joints because of the constant joint mobility. They are running, they are walking, and the children, they start presenting when the child starts crawling. So that is the first time the child of severe hemophilia generally presents with. Otherwise, they do have mouth bleeding, epistaxis, the easy bruising on sudden trauma. There are muscle bleeds also. Sometimes the large muscles like iliopsoas, they also get involved, and blood in the stool or urine. The deadly hemophilia bleed is in the CNS. So the child may present with intracranial bleeds also. There are chances of menorrhagia in the carrier female also, not only with the hemophilic female, but carrier female also. So this is a typical joint which is seen, typical joint with the bleeding. And this is the normal joint. So one can see how much bleed can occur with the hemophilics. So any kids with the bleeding, that suspicion of the bleeding disorder, with this bleeding disorder, we should go for the hemophilia and hemophilia B workup only after taking the good clinical history examination, and then with the confirmatory diagnosis, that's PT, APTT, platelet count. So what we have is generally APTT, which is prolonged in hemophilics. When the APTT is prolonged with the suspicion of hemophilia, to confirm that diagnosis, we need to go for a factor 8 and 9 concentration analysis. So factor assess, and that will stamp our diagnosis. If we want to go further, we can go for the genetic analysis and the carrier detection also. So let's start with the bleeding. So in my case, the patient of 6 months, 7 kg, scheduled for the circumcision, and the pre-op investigation was done, which is normal. Now, after post-op, there is complaint of continuous bleeding from the surgical site. So what happened wrong? Circumcision was done, pre-op was normal, why the hemostasis is not achieved? Any guesses? So generally, sometimes we skip doing APTT in the pre-surgical profiles. So PT was done, which was normal, but when the APTT was done, it was prolonged. So the child was hemophilic. Now we can investigate this child further and can do for the factor 8 and 9 assay, and accordingly we can give any of the factors. But the problem is sometimes these factors are not available with each and every site. So is there any other alternative for this factor? Actually, in current era, you should go for the factors which are either plasma factors or the recombinant factors. But if it is not available nearby, then yes, we can definitely go for the older therapy like FFP and the cryoprecipitate. So the bleeding stopped after giving the appropriate therapy, and the carrier detection was taken. Let's go for case 2. This child, we were not knowing that whether the child was having hemophilia A or B. Now this child, 8 years old, is a known case of hemophilia, had acute pain and swelling in the right knee joint. So it is a spontaneous bleeding. That was the target joint, and the child started bleeding. What is the immediate management? Because it will take time for the child to reach to the hospital. So the immediate management is the price therapy. What is price? So price is It is protect that joint, rest that joint, ice application, compress that joint, and elevate it. It should be within 2 hours. Within 2 hours, an adequate clot-clotting factor should be given to that child. So apply price therapy for half an hour, take that child to the nearby hospital, and give them the appropriate clotting factor within 2 hours. So this was my patient who was doing the price therapy with all the elevation, restriction of movement, ice application, and joint immobilization. But see, this patient is in such a pain. So any bleeding in the hemophilia is really taking a child to very great pain. After price therapy, what is next is the early treatment by CFCs, clotting factor concentrates. And the CFCs, they require the appropriate dosing. So what are the CFCs available? As I said, FFP and cryoprecipitate, but we don't know how much of the CFCs they contain, exact amount. So there are 2 others, like recombinant factors, and in recombinant factors, they have genetically engineered these factors and produced it. So there are less chances of plasma-derived infections like HIV and HBsAg to be transmitted. These recombinant factors can be given to the child. What dose? So actually we need to check for the baseline factor. So in PWH, it is less than 1%, we can consider it as 0. And in this, we can check for the site of bleeding, because site of bleeding determines how much factor level increase we require. And with that, if factor 8, it will raise the 1 unit of kg per factor, so approximately 2%. And in factor 9, it is equal, 1 unit will raise to 1% only. So that's why the recommended dose is body weight into desired level, whatever we want, how much raise we want, but we divide it by 2 in factor 8 and no division in factor 9 calculation. These are the site of bleeds and accordingly what desired level we want. So generally muscle and iliopsoas, it is 40 to 60, and in surgery or intracranial bleed, we need to raise them to 100%. How many days we need to give? So surgery and intracranial, we need it prolonged for 7 to 10 days at least, and all other bleeds, depending on severity, but generally at least 3 to 5 days. So this case was continued, patient was given SHL. What is SHL? It is standard half-life factors. So the factors I am talking about, they come into 2 types. One is SHL, standard half-life, and another is EHL, that is extended half-life factors. The half-life of these factors has been extended by some methods that is known as pegylation. So if it is standard half-life, which is generally available everywhere and along with the plasma factors, we can calculate the dose and the child was given for 3 days. Or we can give the EHL. The benefit of EHL is it requires only single dose, because even if with the factor 8, its half-life is around 3 to 4 days, and with the factor 9, the half-life is around 21 days. So the bleed recovered and the option for prophylaxis has been sought. Let's see another case. Factor case 3, non-case of hemophilia B patient. Now for hemophilia B, as we know, price is there and the standard half-life, we will again give it for the same 40% increase as it is the muscle joint, but the dose is reduced, calculated and given, and if EHL again requires only single dose for this child. So early treatment that enables the resolution of the bleeds, it reduces the hospitalization, reduces the, requires only fewer doses and minimizes the joint bleed. And that's why it is required that each and every bleed, it should be treated as quickly as possible and within 2 hours, so that the target joint and the joint damage should not occur. So with every hemophilia, now this is, I'm talking about inhibitor. What is this inhibitor? So it's like a hero is coming and taking care about the fight and everything, but in every movie we know there is a villain which overpowers that hero also. So this inhibitor is a villain for hemophilia patients. We are treating the children with the recombinant factors, they are improving, but these inhibitors the body make and they counteract the effect of factors what we are giving. So 30% of the hemophilia A and 10% of the B, they will develop these inhibitors, and this will mask the effect of factor 8 and 9 which is given, and that will require even higher breakthrough bleeds in these patients. So what are the inhibitors? They are autoantibodies that acts against the replacement factor of 8 and 9, and they develop and they remains as an important clinical challenge. What happens if there is inhibitors? They are difficult to treat patients because they require specific therapy, or factor 8 and 9 will not work in this patient. There is risk of death if there is intracranial bleed and the patient is having inhibitors also. And the worst joints are affected and the quality of life will be very bad to these patients. So inhibitors, we need to have a titer of inhibitors. When you do a titer of inhibitors, there are two titers. One is low dose titer inhibitors, less than 5 Bethesda unit, and a high titer inhibitor that is more than 5 Bethesda units. So with high titer inhibitors, we have option only of bypassing agents. What are the bypassing agents? That is the APCC or the factor 7. So activated plasma complex, and if the titers are low, that is less than 5 Bethesda units, in that patients are of two types. One is low responders, another are high responders. So if the high responder patients, means if you give those patients the factor 8 or 9, they will again have a high response to those factors for producing inhibitors. And in these cases also, we don't have any other option than giving the bypassing agents. But yes, if you have a low titer inhibitors with low responder body, then we can definitely give them the higher doses of the factor 8. So let's go for one more case. This patient of hemophilia A, 6-year-old, 20 kg, had an inhibitor and now presenting with the acute pain and swelling in the right thigh. Immediate management, definitely price. Now the treatment options. We see there are two treatment options with the bypassing agent. One is recombinant factor 7A and another is plasma-derived APCC complex, generally known as FEIBA, F-E-I-B-A. So for factor 7, the mechanism of action is when it is given as a pharmacological doses, it produces a thrombin burst, and this thrombin burst that leads to a stable hemostatic plug. While FEIBA, what is FEIBA? It's an anti-inhibitor coagulant complex containing all these factors, and that's why it produces a good thrombin generation and also completely hemostatic plug. What is the difference between these two, where we should choose which one? So the major difference is generally in the dose and the plasma derived. So it is plasma derived, we have a theoretical concern about transmitting the disease which are decided by the plasma. But now with the ultra 3 preparation filtration techniques, this transmission of the disease is only theoretical. They don't have any more transmission of HIV or HBsAg with the treatment with the APCC. But these patients, they require a large volume, and the half-life which is achieved, it is with the factor 7 it is only 4 hours, while with the FEIBA it is around 48 hours. So if you want a long-term bleeding control, the FEIBA is better than the factor 7, but yes, immediate control, the factor 7 is better in than FEIBA. So can we use them together? Yes, we do use them together in even surgeries also. We give one factor 7 dose, and then with the prophylaxis or maintenance, we give FEIBA as a dose. So these are the doses for the initial treatment and the prolonged treatment for the sites of bleed if the patient is having with the different inhibitors. So FEIBA dose we calculated with the 50 to 75 IU per kg, and in retroperitoneal bleeding around 100 IU per kg. But if mucous membrane or other bleeding, we can go for only 50 IU per kg. Surgery don't exceeds the maximum dose of 52 IU per kg, it should be given at the interval of 6 hours. Prophylaxis can be done with the FIBA or after the surgery. It's a very costly drug, so you should have a good supply of, and we do have a supply of FIBA with the government help, but it's really a costly drug to give it as a prophylaxis. So this case was managed along with the factor 7 and APCC complex as the continued therapy for around 7 days, and then the child was better. So the primary goal should be the bleeding prevention. It should not be the bleeding treatment what we decided, but yes, we need to treat the bleed whenever it is there. And the rule of thumb for bleeding prevention is prophylaxis, prophylaxis, and prophylaxis. How do we give prophylaxis? For factor 8 deficiency, those without inhibitors, we can, with or without inhibitors, can be given emicizumab. So what is emicizumab? Emicizumab is a monoclonal antibody, and it is a subcutaneous injection given either given only at 15 days or 21 days in at every interval. So very nice, that reduces the patient's pain also, reduces the IV injection, prolonged, and the school abstinence. Last slide. So, and without inhibitors, they can be SHL or EHL. Factor 9, we have the without inhibitors only SHL and EHL. The monoclonal antibody for the factor 9 is there, but it is not still available in India. It will be in near future of 6 months, that is concizumab. And we can treat these patients with the prophylaxis better than the acute management. Thank you so much.
Thank you, Dr. Nehal. Is there any questions? If we have any questions, we can. Dr. Nehal, you have rightly pointed out many things about hemophilia, right from the basics and how to diagnose it and also how to manage it. You have explained with the help of your own cases. That's very nice. Thank you, madam.
Thank you so much.
Thank you, ma'am. Thank you, sir. Dear delegates, there's a small change in the program. The next talk on typhoid vaccine is cancelled because of non-availability of the speaker and other reasons. Sorry, sir. We were waiting for you. Oh, sorry. Please, sir. Please. So.